Hi, I'm Tari Turner, Director of the National COVID-19 Clinical Evidence Taskforce and an Associate Professor at Cochrane, Australia in the School of Public Health at Monash University. Welcome to Taskforce TV. I'm recording this today on the lands of the Bunurong people, and I pay my respects to their elders past, present and emerging, and acknowledge that these lands are unceded. In this episode, we're going to talk about the latest recommendations in caring for people with COVID-19 in the community and touch on long COVID as well. And I'm delighted to be joined today by Associate Professor Penny Burns, who is known amongst the task force as a triple threat. Penny is a tireless contributor to at least 3 of our expert panels, the primary and chronic care panel, the paediatric and adolescent care panel, and our previous infection prevention and control panel. And actually, even as I say that, Penny, I realise you were on the Pathways to Care working group as well. So we're going to have to move that up from triple threat to quadruple threat. Penny currently works in general practice at the Northern Beaches Hospital Medical Centre and is involved with the management of respiratory conditions at the Dee Why Respiratory Clinic. Thanks so much for joining me today, Penny.
Thanks, Tari, and I'm very happy to be here. And I'd also like to pay my respects to the Gadigal people of the land on which I'm meeting you today, and pay my respects to elders past, present and emerging.
I want to start with a big picture question, Penny. I'm really interested. This has been such a bizarre piece of time the last couple of years, and all of us have experienced it in different ways. But I'm really interested, particularly in your experience as a GP. What has it been like to be a GP during the pandemic, and perhaps what's changed over the last 2.5, almost 3 years?
So it's actually been an amazing experience, and one of my GP colleagues described it as building a plane and flying it at the same time. It's just been an incredible period of rapid adaptation and change, and sort of having to almost daily react to changes that come in and readapt what we're doing. It's highlighted, in my mind, general practice in terms of its position in the healthcare system, and so I think it has actually linked us in a bit more strongly to the hospital system, the specialist system, and I think that's a really good thing. Still a long way to go, but it's actually been a really creative period. We've gone from a period where we were sitting in general practice, we heard about this, disease that was coming from overseas, and we were all a bit frightened and concerned, and our patients were a bit frightened and concerned, and people were starting to stay away from general practice when they heard that it arrived in Australia. We were getting frustrated trying to provide care, and we were also very nervous. And colleagues of mine working in an area where there was a really high number of people returning from countries that had the virus were also feeling the effects. In general practice, we didn't establish PPE very early on. We're a bit slow to do that, so there was a little bit of fear amongst doctors who were seeing patients without adequate PPE. And then it's rolled over, and we've gone from that scenario to where suddenly GPs are having to manage patients that are sick with the disease presenting. Some doctors got really frightened and closed their doors. Other doctors managed to see them. And some of the rural GPs were wearing garbage bags as gowns, and putting on all sorts of creative methods of seeing people in paddocks and doing that sort of thing. And then we went to the COVID vaccination clinics, where suddenly we're having to not only control infection control, we have to vaccinate people, and we have to do it quickly, and we have to do it safely. So that means drive-through services, not for McDonald's but for vaccinations. And then we went to the antivirals, which just became a headspin for most GPs, because who to provide it to, who not to. And then we've now gone to this really tough period of seeing the consequences of the disease, seeing that large number. I think we've got over 10 million cases in Australia at the moment, and, about 400,000 of those were last year. So we've got, about 9.5 million patients now that have had COVID case this year. And we're getting that, even at a minimum of 10% long COVID occurring after that, we're getting large numbers of patients presented with quite an interesting constellation of symptoms, and not really knowing what to do with it. But I think overall, it's been exhausting, but it's actually also been a really creative time for general practice.
It does just sound like an absolute roller coaster, Penny, and full kudos to you and your colleagues for leading through that period. What are the things that are key challenges right now for GP practices, the owners and general practitioners as well?
I mean, I think in a good way, general practice has got a little bit more confidence in terms of being able to cope with whatever's thrown at them. I remember we had something thrown at us. We're in the middle of a clinic and we had a change in guidelines thrown as we're in the clinic. We're suddenly going, okay, now you no longer qualify for it, go home. So I think we've got a little bit more confidence about, knowing that we can manage whatever's thrown at us. But I think, I think what it's done is it's created a bit of extra stress on what was already a stress system. So general practices have been quite overloaded in terms of work, and this created. Now we're seeing a lot more patients presenting. I'm a Sydney GP in the middle of Sydney, where you think it would be lots of general practitioners, but we've got a shortage of staff in our practice for GPs. We can't get more GPs, and we've got most practices have long waiting lists for new patients, and existing patients are having to wait a week or more to get in to see their GP, which is not perfect. I think the other problem is financially. There's a bit of an issue for GPs as well, because they've laid out a lot of extra cost in adapting all these sort of measures, and it means that it's been hard for some general practice to survive. So that's it's a business structure that's the main issue at the moment in terms of surviving. And then the other challenge, I think, for general practice, which is going to be really interesting, and I don't know where it's going to go, is how general practice will work in the post-pandemic era. So prior to COVID, we didn't really focus strongly on infectious disease in general practice, in that we would sit in front of a patient coughing and we wouldn't have a mask on. And I remember my infectious disease friends would laugh at me, like, how can you do that? But everyone was coming in coughing, and we couldn't mask up for everybody. Well, at the moment we are masking up for everyone. So I think the challenge is going to be, how do we do that in a reasonable way? Because we also see patients who can't hear when I've got a mask on. My elderly patients, they don't like the mask. They don't feel like they can breathe. So they're coming in trying to connect and talk to their GP, but they can't hear them. So I think there's a lot of challenges moving forward for general practice.
We've also already kind of segued to the next question I want to ask you, which is, we've been talking a bit about the impact of COVID on GPs, and obviously it's been enormous, but obviously it's also been a big impact on patients, both patients with COVID-19, but also the implications for patients who don't have COVID-19, but who are presenting with their normal everyday illness in the context of COVID-19. Could you tell us a little bit about what it's been like for your patients to be experiencing COVID-19 or experiencing the results of COVID-19?
Yeah, so look, I think firstly, I'm almost seeing more effects not related to post-COVID in a way, or long COVID, but the general effect on patients accessing general practice has been really difficult. I've had a number of very frustrated patients come in because they've felt like that, in various periods during the pandemic, because they felt like they haven't been able to access care. And they're going, well, what am I supposed to do? I can't come in, particularly parents with young kids, or they'll come in frustrated because, like, I've got this ongoing cough. I've had it for 6 weeks. I can't go to work. I can't go anywhere. What am I supposed to do? I can't even come in here because you make me wait outside, or, And so I think huge amount of frustration. I think there's still an ongoing number of patients, particularly the elderly, who are actually somewhat frightened about coming in. They got really good at hibernating away. That was the way to keep them safe. And then now coming into a general practice where people are coughing or even going out and doing other activities, I think is really hard. And the problem with that is that group particularly have not had their ongoing chronic care. So we're catching up on a lot of normal care that we would have been doing, and people have prioritised that haven't prioritised that. So we're seeing people needing to come in and getting all sorts of routine care done, and that means we're seeing sicker patients. I'm not sure about the fragmentation of care, but because practices are really overburdened at the moment, I think also we're seeing patients coming to our practice who couldn't get in to see their usual GP in a timely way. And so we're getting that breakup of care. I work in a general practice in a hospital in Sydney, so we tend to see a lot of semi-acute cases as well, but we're also seeing patients who are just frustrated with trying to access care. And then I guess the telehealth has been great. So telehealth's been really useful, and I think patients have really loved that. And it's also given us closer contact with patients who aren't keen to travel. But I think the other thing it's done, there's my usual patients I seem to actually have got a much closer bond to during this period. So they really want to come in, they really want to see their usual GP. It's almost like a sigh, and they need guidance with this advice.
You've already mentioned that those millions of patients who are potentially at risk of post-acute COVID symptoms or long COVID symptoms. Many of them, of course, won't have any symptoms, and the difficulty of assessing a patient who has a combination of symptoms that might be very different from the next person. What do you think clinicians should be aware of when they're seeing a patient in front of them who's had an acute COVID infection in the past and is now presenting with, what might or might not be post-acute or long COVID symptoms?
Yeah, so I think this has been really hard for clinicians, and we've had lots of discussions, and we have a little WhatsApp group where we chat to other GPs, and we say, what do you think about this one? And that, so it's for us, it's GPs have dealt with uncertainty regularly. So in every day we see undifferentiated presentations coming in the door, and someone's got a sore, a sore thumb here, and they've got a rash on their thigh, and what does that mean? And we're like, oh gosh, we're uncertain too. So we're used to dealing with uncertainty within patients, and the way we approach, I guess, long COVID is probably going to be similar to the way we approach other uncertain conditions, and it's very much around a person-centered sort of holistic approach. So we end up having to take a step back and take a really comprehensive view of this patient. So as GPs, we often understand their previous history, we understand their personalities, we understand, what exacerbates their pre-existing conditions. But what we need to do with patients that are coming in where we suspect that there's a post-COVID event occurring is we really need to go through really comprehensively what their history is in terms of the COVID-19 episode that they had, the nature of the symptoms, the severity of the symptoms, how long they last, and then also what's I think is really, really important is we need to ask them how they're experiencing those symptoms and how it's affecting their function in day-to-day life. Is it affecting their work? Is it affecting their relationship? Is it affecting their ability to go out and garden, their ability to walk down the road? And when you start asking those questions, I'm often amazed at how restrictive some of these symptoms are that I would have thought didn't sound quite as restrictive. I think in general practice, one of the key things we often do with patients is we acknowledge that they've actually got those symptoms. Sometimes they come in thinking, everyone says, get over it. You won't, that's not, you should have got over it by now. I was over it weeks ago. And so I think there's that anxiety around that, which is unfortunate, but still at the moment. The difficult part comes when we get patients that have come in with, so an elderly person who's got some gradual decline or deconditioning or worsening frailty. And we have to constantly go back and say, is that related to a previous COVID infection? And so I think that's also really important. And then I think also the other thing with long COVID that I've been learning is that a lot of the management of these patients is going to be self-management. And so it's about helping them develop a really good plan around each of those symptoms and how to sort of have a stage sort of method of managing that, when to come back and ask for help because it's deteriorating or something serious is happening, and when they might need to see a specialist. But otherwise, it's a matter of trying to basically step by step take them through a program where they can slowly try and improve their function.
You've already kind of highlighted that there's a lot that's unknown in this world of long COVID, and we're very hopeful that there'll be new research studies coming down that pipeline. And obviously being on the panel, you guys have had to come up with consensus recommendations based on your experience and your expertise and what you know from other conditions. I'm interested to know what questions are people asking about long COVID that we might get answers to in the near future? What are your colleagues, what are your patients asking? What are the questions that are front of mind for people who are facing long COVID or wanting to care for people who might have long COVID?
Yeah, that's a really difficult question, Tari, and I'm not sure I actually know that. I mean, one of the key concerns I find, and so this is not quite answering your question, but the key concerns people have is this uncertainty. How do I know it definitely is? How do I know what my path's going to be, my trajectory, my experience of this disease, and how do I know that what the best care is, and I want to get that best care. So how do I access that? So I guess in terms of, and that feeds back into the need to have this evidence base behind us so that we can ensure that we are providing that best advice. And then if that's lacking, then have that expert consensus. And I mean, that's where obviously I think the National Taskforce guidelines are fantastic because they step you through all those things you need to do for a patient with this condition. In terms of what we need next in this space, I think I actually think that one of the questions we've been asking a lot is the longer term prognosis. So if I can get through the next 2 years, what am I going to be like? Will I actually still have this? Is this forever, or am I actually going to recover from this? And I think that's something that I would love to be able to tell my patients. I'd like to say, there's a 5% chance you'll have it at 10 years and hopefully 1%, that there are definite things you can do. So I guess I would like to see more evidence, more gathering of the evidence, just as the task force is doing. And I'd like to see this as an ongoing process. And then really, again, rapid updating of guidelines, rapid output to those practitioners that are using those guidelines. And I think that's really the key at the moment. I don't think any other questions are a higher priority than that.
It's clear we've still got a lot to learn, and hopefully that work is being done. My last question, Penny, is a hypothetical one, really. It's, if you had a magic wand, a genie in a bottle, one wish, what one thing would you change to improve the care for people with COVID or after COVID in the community?
Whoa, I'd get rid of it, but I'd have it stop at 12 weeks. But look, I think it actually goes back to that. I would like to see a really clear understanding of the disease out there. I would like to see long COVID become a condition that becomes one of our normal chronic care conditions that we manage all the time. So patient comes in with diabetes, I know exactly what I need to do, what I need to check, how I need to manage that. And it's different for every patient, but I feel very confident about the evidence and the management that I'm providing. I would love to see that with long COVID. I'd love to have confidence when patients come in and say, here, this is a checklist of symptoms. This is what you might experience. This is what you may not experience. This is most likely to last for a certain period of time. In very, very rare cases, it might go a bit longer. These are evidence-based, proven therapies that will work. And if you follow these, then you will improve and go on to have a long, wonderful life. And for me, I guess that would be the most important thing. The only thing better than that would be, let's prevent the disease and let's get rid of COVID and have it like measles, as declared officially extinct. But we'll have to wait and see on that one.
I'm very happy to keep working with you on both those fronts, Penny. Thank you so much for your time today. And I hope everybody who's watched this has enjoyed listening to Penny, and I encourage you, if you've got questions that you'd like us to ask people like Penny or her colleagues in the task force, let us know. Feel free to send those in. And please do share this episode with your colleagues and look out for our next. Thank you very much.